Sorry, my slides don't seem to be moving on at the moment. So, as I said, today is day 2 of a 3-day event. Yesterday's sessions were very interesting, and there was lots of engagement and discussions. We heard first from Dr. Andrew O'Regan and Professor Liam O'Glynn on findings from the Move for Life research as they relate to physical activity and health and physical health, and then from Dr. Grainne Hayes and Professor Alan Donnelly on findings from the research in relation to sedentary behaviour and its impact on health, and that generated a lot of discussion. And then in the second part of the afternoon, we heard from Mary Harkin from Age and Opportunity on their research that was carried out with older adults during COVID. And it was very aptly titled Locked In, Locked Out and Locked Up. So for those of you who weren't able to be here yesterday, those sessions are recorded and you'll be able to listen back to them on the link when they're shared. For those of you who were here yesterday, my apologies, because some of what I'm going to go through in the next few minutes will be familiar to you, but I can guarantee you that we have a very exciting agenda lined up again for today. Throughout the day, you will be hearing in some video snapshots from participants, researchers and tutor voices that participated in the research. It's really important to us to showcase those as part of the conference, because without those, the research wouldn't have been possible. Our first session, which focuses on, I suppose, the academic research component of the project, will be looking at recruitment strategies, getting the message right, with input from Dr. Andrew O'Regan, and then the intervention development with insights from Dr. Enrique Garcia and Amanda Clifford. And that session Q&A will be chaired by Professor Stephen Gallagher. And then in the second session this afternoon, which our second session will focus more on how some of the insights and learnings from the research project can be applied in practice, and it's very practice focused. So to be looking at the measurement of physical activity with input from Dr. Grainne Hayes and Caera Grady, and that session Q&A will be chaired by Mo Foley-Walsh. So really looking forward to an exciting afternoon. Now, so I suppose setting the scene and giving the context for the Move for Life research, we know that one of the biggest challenges facing both Ireland and countries across the European Union is the ageing population. Over the next number of decades, we can expect the proportion of those aged 65 plus to double, and those aged 80 plus to quadruple from the 2011 baseline. And the challenge we face as a society is how we take steps to ensure that from an individual and a society perspective, that everyone continues to have a good quality of life for as long as possible throughout their later years. We know that functional capacity can start to decline around the age of 50. And while all around us, we do see older adults who are happy, healthy, engaged and contributing to society, the challenge for us is how to ensure that this is the case for the majority of our older population. So in terms of policy and strategy, the National Positive Ageing Strategy, published in 2013, is still our guiding strategy for work in this area, and it really set out to address that challenge of ensuring a society that is fit for all as we age. So it sets out a vision for a society that for all ages that celebrates and prepares properly for individual and population aging, enabling and supporting all ages and older people to enjoy physical and mental health and well-being. It puts a focus on promoting and respecting engagement in economic, social, cultural, community and family life, fostering the equality, independence, participation, self-fulfillment and dignity of older people. And the piece from Mary Harkin yesterday afternoon will definitely have caused us all to have paused and reflected on how Well, those key themes of the positive aging strategy were lived over the last 18 months or so as part of the pandemic emergency response. The positive aging framework is one of the steps. The creation of positive aging framework is one of the steps of implementing the healthy aging strategy. It sets out 3 goals with an overarching goal 4 that encompasses addressing issues of stigma, information provision, ageism. Goal 1 looks at removing the barriers to participation and providing more opportunities for continued involvement by people as they age. Goal 2 focuses on supporting people as they age to maintain and improve or manage their physical and mental health and well-being, while Goal 3 focuses around enabling people to age with confidence, security and dignity in their own homes and communities for as long as possible. In the context of the Mood for Life, the element of Goal 4, which as I said was a cross-cutting theme that ties very closely to the Move for Life work, is the provision of timely and regular access to comprehensive information about all determinants of health, well-being and the quality of life. Falling out of that, the Healthy and Positive Aging Initiative was established as a collaboration between the Department of Health, HSE, Age Friendly Ireland and Atlantic Philanthropies. Key strands of this initiative were to establish a set of key indicators for older persons' health and well-being using existing research and data. Establish a research fund to commission targeted once-off research to fill data knowledge gaps relevant to the design or configuration of future services and supports for older people. And it also committed to publishing a biennial report on the health and well-being of older people and publishing a series of county reports. The Healthy Positive Aging Initiative has come to a close now, and I suppose the presentation today and the findings from the Move for Life is one of the last elements of that initiative. So in terms of the focus around the research and research fund, a research strategy was published in 2015 for healthy and positive aging for all. There were 2 research calls across that period. In 2017, 3 research projects were funded, one looking at dementia-friendly service and inclusive design in hospital spaces. The second looking at the life course and structural determinants of subjective health among older adults who are members of the traveller community or homeless. And the third looked at inequalities in palliative care for older people. The second research call then focused on physical activity, and the research arising out of that was the Move for Life project, which you'll hear about today. So I suppose when we're looking at physical activity and looking at the Healthy and Positive Aging Initiative, the key question is, why did we choose to focus on physical activity? So we know that only 38% of older adults are meeting the national physical guidelines for physical activity. We know that the rate of long-term illness increases with age, with 61% of adults aged 50 plus having a chronic condition such as arthritis, osteoporosis, cardiovascular disease, respiratory conditions, and diabetes. And as adults age, the number who are living with 2 or more conditions increases. And significant evidence, both international and national, exists to show that where adults are meeting the national physical activity guidelines, for physical activity, this promotes well-being, physical and mental health. It prevents disease, improves quality of life, and has economic, social, and cultural benefits. So the positives for are planning for a society where people live well into later years are huge from increasing physical activity. And the Royal College of Surgeons in Ireland have recognised this, having termed physical activity a wonder drug, primarily because of the positive impact it has on both reducing the risk of disease and illness, as well as the benefits of being regularly active for those who are living with chronic disease. So irrespective of the all the evidence of the benefits of physical activity, increasing lifelong participation in physical activity continues to be a challenge. In the Lancet series on physical activity in 2016, it was observed that while many countries are taking action to improve physical activity through publication of policies and action plans, implementation and consequently the impact at individual and population level remains weak. The authors, Rees et al., theorized that the greatest progress is likely to occur through interventions that are effective in promoting physical activity, implemented at scale, regularly assessed and fully embedded in an enabling system. And this is what the Move for Life project set out to do. So the purpose of the study was to develop a community-based intervention that would address the problem of inactivity, be easily implemented and embedded within the existing system designed for the promotion of physical activity in adults living in Ireland, which is primarily delivered through the local sports partnership network. Key questions that the research team and their collaborators set out to address included: how do we broaden the reach of programs to more participants and make them sustainable long term? And the research team, working with key partners including Clare and Limerick Sports Partnership, Age and Opportunity, the HSE and the local people, theorized, or I suppose hypothesized, that the Move for Life intervention would work by empowering both professional and non-professional members of a community, using a cascading model to teach behavioural skills and provide informational and social support. And as a consequence of that, there would be an increase in physical activity, regular physical activity participation. The little graphic there to the side tries to illustrate the potential impact in terms of cascade and reach. So the research team used a 6-step intervention mapping approach, and the research project was carried out in four strands, and it was very much about trying to take knowledge and apply it in practice and learn from that experience. Strand 1 was understanding the evidence. Strand 2 looked at developing the intervention, and you'll hear some more of that today. And Strand 3 was around testing and evaluating it in a real world scenario. And in Strand 4, which is what we're in now at the moment, it was about sharing the learnings from all of this. So you'll see here the research team who led the project, and they're members of the University of Limerick, University College Galway, Limerick Sports Partnership, Clare Sports Partnership, Age and Opportunity, and Limerick City and Council are there in that picture, and some of you may recognise yourself there. The initiative was launched, the project was launched here in April 2018 by the President of the University of Limerick, Dr. Desmond Fitzgerald, and the Minister of State, Catherine Byrne. And it was heavily advertised and promoted in local media to encourage engagement and uptake. Throughout the research project, a number of tutors and peer mentors across the 2 counties of Limerick and Clare and the 8 sport and physical activity hubs in the region that participated were trained and upskilled. And this picture shows Professor Catherine Woods, the principal investigator on the research project, with a number of those tutors and peer mentors. The testing and the data collection for the research project took place in sports halls, community halls, inside and outside, from May to September in 2018. And it included a range of assessments. There was a huge supporting workforce there from the research team and students in UL and volunteers from the local sports partnerships who made it all possible. The project itself, 733 people took part in the Move for Life project, which was absolutely fantastic. And you'll hear throughout yesterday, today and tomorrow, the impact that the project has had on those participants. As I mentioned earlier, we're in strand 4 now of the sharing the learnings from the project, though as a lot of the work has been happening over the last year or two also. The research team presented at a number of events, and a number of papers have been published on it. And also you will, a small mini documentary was made by Missy Knowles and Trevor Ferris, and you'll see some of that in yesterday's event and possibly later on today. Many of the papers and the findings from those published papers will be discussed in the academic sessions across yesterday and today. So this is the research team saying a big thank you to all the Move for Life participants and tutors and funders, and on behalf of the funders, the Department of Health, HSE and Atlantic Philanthropies, I'd like to say a huge thank you to the research team, to the participants, to the tutors, to all the partners and everyone who made Move for Life a reality. So I'm just going to finish there and hand back to Ciara, or sorry, is it Stephen? Sorry, hand over to Stephen for the first session.
Yeah. Just before you start, Stephen, I'm just going to play a short video, okay?
Hands on the ball and move to the side, and don't let your feet twist to the same side.
As our physical health starts to disimprove, and as we get older and maybe we develop chronic illnesses, the effect of actually moving, of being physically active, not only will help that patient's lung disease and their heart disease and their arthritis, it will also help the mental health. It will help to lift the mood of that person.
It makes you feel so good, and you're freer and able to move a lot better.
So if we can make people active, we can give them the same level of benefit that we give them if we make smokers give up entirely.
As a GP, as a researcher, it is immensely rewarding to see a real impact and a positive change happening in the lives of real people.
Over to you, Stephen.
Okay. Again, I want to just thank Sarah for giving a great overview of what the Move for Life actually is, and in the context of which the study was actually set and where the initiative came about in terms of positive and healthy aging. So it was a really good overview. And so we have a number of speakers today, and the first one is Dr. Andrew O'Regan, who is the GP and a researcher here in the School of Medicine in the University of Limerick. Andrew has a strong clinical interest in promoting physical activity for the prevention of chronic illnesses. His primary research interest concerns engaging older adults, and Andrew was the guy you've seen in the video there promoting it. He is currently enrolled on the PhD program here. He's in his final few years, and the PhD is based on the Move for Life. Some of Andrew's personal interests would include obviously nature, Gaelic games, and hiking around his local area in the hills of Kerry. So Andrew, I'm going to pass over to you now, and you can tell us your ideas and what you found about the recruitment strategies for the Move for Life.
Thank you very much, Stephen, for the kind introduction. Can you see my slides okay?
Yes.
Great. So I guess one of the big, or maybe the big learning point for me in my involvement in Move for Life was just how big a deal recruitment is. You're planning any kind of research, but in particular randomized control trial, getting people interested and getting them involved is such an enormous piece of work, and it has to be done really, really well. And for the next 10 to 15 minutes, I'm going to speak to you a little bit just about how that recruitment was planned and what went into that, and also how it operated, how we did it in practice. And I just see with the names, some of the people here were involved in that recruitment process, and you'll be aware that it would have involved meetings upon meetings of planning it, of getting the strategy right, and an entire team was dedicated just to recruitment. And this would all have been news to me before this all started in 2018. And if we just pause for a second and think, well, what do you mean by recruitment? What's involved in that, and why is it such a big deal? Well, Enrique is going to tell us with Amanda later about how we designed and developed Move for Life. But none of that would be any good if nobody came in the door. So recruitment is about promoting the information, getting people interested, and reaching the right target population. So in the case of Move for Life, we were interested in inactive adults aged 50 years and older. And what a disaster it would be if the first night, on the first recruitment night, if everybody that walked in the door had the appearance that they were maybe trying out for the Limerick hurling and camogie team. So it's about getting that right target population in the door. And I think it's worth stating as well at the start that we had a very short lead in time. So that time between the project or us meeting as a team and Move for Life starting and the time of the programs being rolled out, there was only an interlude there of months. Whereas for other studies and other randomized control trials, this might be going on for longer than 12 months. So that's just important to keep in mind. And the other thing to keep in mind when we're talking about recruitment and getting the right audiences is what general practitioners, and I'm sure a lot of healthcare professionals are aware of, this Tudor-Hart inverse care law. So Tudor-Hart, he wrote about the inverse care law back in 1971. And basically what he said was the availability of medical care is inversely proportional to the need for it. And what he was speaking about at the time was, okay, medicines and the most up-to-date medicines for, we'd say, diabetes and heart disease, and the people that needed them most were often poorer people, and they were the ones that had least access to them. But if we fast forward now to 2021 and we're thinking about the realm of physical activity for health and physical activity maybe even as a medicine, well, then we've got to think, who has the greatest need for this medicine, for the medicine of physical activity? I think that some of the groups that would come to mind are obviously those that are least active and those that are most sedentary, people with chronic conditions. And now as our population is getting older, we have people getting more than one chronic condition at one time. So they might have arthritis and asthma and heart disease, and they might have diabetes as well. And we call that multimorbidity. And then the law, the inverse care law remains the same. Those who are in the lowest socioeconomic groups, so the least educated, those who have less financial means, and those that are marginalized are also less likely to have physical activity opportunities and to engage with them. So just looking at previous research that was done in primary care populations, and they were trying to study the effects of physical activity programs. There are two here, one by Harris and one by Harold. And when they looked at recruitment, they both found similar enough findings. Harris found that the problem with the people that he recruited was that they were nearly all healthy and interested in physical activity anyway. And that was Halbert, and Harris reported that there was a strong bias towards the participants in their trial being more active than the general population. And because they were recruited in primary care, they found that there was a weaker bias towards them having more health problems, which I guess was a good thing. They were getting in people with multimorbidity. So before we ever started our recruitment strategy, we were aware of those pitfalls, that we didn't want everybody coming in to be super fit, and we didn't want the healthiest and most well off and most educated coming in. We wanted to make this appealable to everybody. So as a key part of this, of Move for Life, and a key part of recruitment, a qualitative study was carried out. And what that meant, just for people that are maybe not as immersed in research as we are, a qualitative study is when you're not getting people to tick boxes, or you're not watching their behavior, you're asking them why. You're trying to get to the heart of the matter to understand people's perspectives. And we were interested, of course, in the perspectives of older adults. And we recruited 30 older adults to talk to us and to tell us about their experience with previous physical activity programs. And we also recruited 17 professionals and advocates who were involved either in the design or the delivery or the promotion of physical activity programs in the past. And we wanted to ask these people, what do we need to do to get recruitment right, and then to get sustainability and scalability right as well. And in particular, we wanted to find out about the harder to reach, the very old, socially isolated people from lower socioeconomic groups or the marginalized. And what we found in this study, which was published, and this is from the publication, this diagram here, was just some key concepts in relation to recruitment, sustainability, and scalability. And we'll just speak to recruitment in this talk, but for recruitment, the number one thing that came across was that you needed to have age-appropriate messaging, that how we did the communication was absolutely key to success. I'll talk a little bit more about what that means in a minute. But other things that came up for recruitment were everything is local. So to think about what are the local hotspots, where will the target audience is likely to be found? And we thought about that. We thought about things like, well, maybe the local community centres, maybe that because they're older, they go to the doctor and the HSE physiotherapist more. So they all became a part of our recruitment strategy. Other local hotspots, parish centres, parish newsletters, things like that. And then thinking about local assets. So an asset, if we're thinking about assets in terms of health and physical activity, that can either be a person or it can be an organization. And local assets would be well-known people respected in the community who might champion this cause and spread the word to other people. And other things like organizations, things like GAA, things like active retirement groups. And then non-traditional strategies, well, that basically meant thinking outside the box. And I'll tell you a little bit more about that as well. But going back to getting that message right. So what we were told by some of our participants is to think about the language that we used, a reassuring language that older people could identify with. So what's not on the screen there is that another participant told us how, it's really off-putting if you're older to be, displayed a picture of somebody in Lycra as if it's a HIIT class or one of these CrossFit classes, that everything from the imagery to the naming to the language should be aimed at and should be at the level of the people that were interested in getting involved. And so what that meant was examples of that might be, putting up, images of people holding, weights that are, don't look like they'd be impossible to lift, holding those, can't remember what they're called, but those sticks, for walking sticks, I guess you call them. All that sort of imagery was really, really important. So what were we trying to get across? That Move for Life would be fun, that you'd have an opportunity for social interaction, that we would be clear in what it was about and what it was not about, that it was not exclusive. You didn't have to be super fit to be in there. In fact, we'd prefer you weren't, but that it had to be doable as well, while at the same time presenting a challenge. So our recruitment strategy involved, based on all of that, our recruitment strategy involved traditional and non-traditional methods. So the traditional were the local media, our presence in the newspapers. Catherine did radio interviews, a big launch, which was mentioned earlier by Sarah. You see the picture of it there in the background, involving a Minister for State as well as the President of the University. Flyers, just ways of getting the information out there. And in non-traditional, possibly the biggest and most important thing was that partnering with the local sports partnerships. So having this organization that were deeply ingrained in the community and had big access to people was going to be a key part of our recruitment. Other things, members of the team went to local community groups. We went and we spoke to healthcare professionals. I spoke to groups of GP colleagues. As mentioned, we got the news out in parish newsletters, but also social media was taken as well. So then, if you just look at the overview of recruitment, the multiple recruitment strategies, we got interested individuals were able to make contact with us either through phone or email or on the website. And then they were invited to an event at a community centre. At this event, they were given further information, informed consent, and baseline health measures were taken. You'll hear more about those health measures later. And then, as Sarah's already mentioned, 733 individuals were recruited and turned up to those recruitment evenings. In terms of, well, give you a bit of context about that. That would be far in excess of many other similar physical activity interventions, getting that many people on board. And in our own protocol, which we'd published prior to recruiting anybody, we'd aimed for absolute best 560 people. So we were well in excess of our own target. And in terms of the success of getting the message right, 98% of the people that turned up were happy to give consent and take part in the study. We include some people, which is, you'll find that with every single piece of research, some people were either too active and some people were too young. And then of those that did come in the door to us and did start, about 4 in 5 were female. 37% had greater than 3 chronic conditions, which anybody here with a chronic condition will know it makes a huge impact on your life, and having 3 makes life a lot more complex to manage. And 41% of our population were obese. So that would be a little bit higher, well, quite a bit higher than the national average, which is 36%. So big implications there with obesity as well. And then just to tell you about how participants heard about Move for Life, by far the biggest way of hearing about it was word of mouth. And the graph you see there is broken down into male and female. And you'll see for both genders, it's far more effective to get people there through word of mouth. But you'll see other interesting things as well, how effective the newspaper, having editorials and having ads in the newspaper was effective. You'll see email from the local sports partnership was effective as well, and far more females again than males hearing about that. And then some of you might notice over to the right hand side, you'll see other, and a big part of other was actually Facebook. So there are quite a lot of people, 50 plus, who are using Facebook and hearing about things through Facebook. But we went a step beyond that when we got our participants and asked them, well, apart from the main way that you heard about Move for Life, was there any other way that you heard about it? And quite a number of people did hear about Move for Life through a second source, and maybe even a third source. And again, the newspaper was high up there, but you'll also notice for both genders, email for the local sport partnership as well. So big one there. So after all of that, what did we learn? Well, we learned that it's not one size fits all, that if you want to get people in the door, and if you want to get the people that you're looking for, the inactive and the over 50s, multiple strategies are necessary. And word of mouth seems to be the biggest one. So hearing about Move for Life from somebody that you know, from somebody that you trust, and maybe somebody that's going anyway. And one big thing that stuck out for me out of all that was that we need to focus on ways of getting more men in the door. And this has been documented in the research as well, that it is harder to get men into these sort of programs. So other considerations might be targeting men's sheds in the future, other men's groups, and maybe having male champions there, and that will maybe serve as an example and as a role model for men to come in the door. So I guess finally what I'd like to say is that the recruitment was done in a really short time space, but we far exceeded our target of 576 participants, and we got people by and large that were inactive and older. So I think we can be very happy with this recruitment strategy, but also we can take a lot of lessons from it and apply them to a future trial, hopefully. So just before I finish up, I'd like to thank you for listening. I'd like to thank all the collaborators, the funders, the researchers, and of course the participants, without which this wouldn't have been possible. So thank you. Back over to you, Stephen.
Andrew, thanks very much. We're not going to take questions immediately after this. We're going to wait until the next speakers have finished, and then we'll take open the floor up to both talks. So next we have up is Dr. Enrique Garcia. Enrique is again part of the project. He's currently coordinator of the Irish Physical Activity Research Collaboration with Sport Ireland. He's also a researcher affiliated with the Physical Activity for Health Research Cluster of the Health Research Institute here at the University of Limerick. Enrique's interests are in physical activity promotion, the social determinants of health, knowledge translation, participatory action research, and again, active living and the environment. And prior to coming to Ireland, he's worked and lived in Australia, Canada, and Spain. And we also have immediately after, we have Dr. Amanda Clifford. And Amanda is course director of the MSc in Physiotherapy and a senior lecturer here in UL in Physiotherapy. Her research program of work includes the design and evaluation of evidence-based interventions to optimize health and well-being, prevent falls in older adults and people with neurological conditions. She's previously worked clinically at Brighton and Sussex University Hospitals, NHS Trust, and the Whittington Hospital in London and the Wellington Hospital, St John's Wood. And she has experience in the treatment of people in acute medical wards and rehabilitation settings, including neurological rehabilitation units and outpatient falls clinics. And in terms of outpatient experience includes the management of people with acute and chronic musculoskeletal, orthopedic and rheumatological conditions. So I'm going to hand you over now to Enrique and Amanda.
Thanks so much, Stephen. Can you hear me okay? And are the slides up?
I can hear you okay, yes.
Perfect. And the slides, are they okay? Perfect. Yes. Great. So it should have the Move for Life intervention development slide up. Is that okay? Yeah? Great. Thanks so much, Stephen, for the introduction. And thanks so much as well to the presentations that were beforehand. So Sarah, thanks for your great overview of the project, and also to Andrew, who spoke about the recruitment strategies. Myself and Enrique are going to talk about the intervention development. So good afternoon to everybody. And in this presentation, we're going to describe the development characteristics of Move for Life, which was designed to help inactive adults aged 50 years and older increase their levels of physical activity. So this talk will link with some of the presentations that went beforehand, but also will link with presentations that will be on tomorrow, and especially tomorrow afternoon, where John and Phelim are speaking in session 2 about research in physical activity, the LSPs, what they have learned. So in terms of the content of the intervention that we're going to talk about today. So I'll just mention a few slides at the start, just to put in context how the intervention was developed. And then Enrique is going to take over, where he'll talk a little bit more about the intervention mapping and what it contained. So just to reiterate some of what Sarah said earlier, where she spoke about the physical activity guidelines and why they were so important. So the World Health Physical Activity Guidelines describe the appropriate levels of physical activity that are recommended to maintain health, prevent delay of disease, and optimize health and well-being. So you can see here all of the different aspects that Sarah mentioned during her presentation. And also she mentioned that only 38% of Irish adults are sufficiently active to meet these physical activity guidelines. So that sets the foundation by which then this particular project and a lot of the motivation for why it was that this particular project happened. And also you heard in the previous presentations where they spoke about which interventions are likely to be effective, and those that are implemented at scale and fully embedded in the community are those that are thought to be more effective. So that sets the scene for why it was that why we did this project and Move for Life itself.
Sorry, Amanda, to interrupt you, but I think that we're not moving on in the slideshow.
Oh, sugar.
Yeah, we're still stuck on the first
one.
one.
Are you? Okay, let's see. So if I, let's see, share the screen again, perhaps,
If you
and
share
then
the screen,
hopefully it'll work again.
Yeah, we're on the pragmatic approach.
Brilliant. Okay. So the first slide, just see that it's changing for you. The first slide where I was just, I suppose, mentioning what was mentioned before is this slide where why we meet the physical activity guidelines, and following on then is the pragmatic approach. So we took a pragmatic approach when we were designing the Move for Life intervention, and this was so that we could provide some practical results that were going to be more appropriate for real life settings. And this, I suppose, further consolidates what Andrew was just speaking about in terms of the real world, and for people who are in the communities, that it's not very structured in terms of that it's a practice that could not happen outside of the research. And the pragmatic design was relevant for the participants, so inactive people over the age of 50, and in these settings that are as close to usual practice as much as possible, so that the results then were more relevant to participants, to providers, to policymakers, and will much more help in terms of the decision making about the feasibility of this particular community intervention. So what we did was we used the framework of looking at an evidence-based practice approach where we had the 4 pillars of evidence. So instead of creating an intervention solely based on just theory and research, we used the 4 pillars of evidence-based practice to augment the well-known existing programs that were in place in the community. And these 4 pillars are the best available research evidence, the needs and preferences of participants, the practice expertise of the people who deliver these interventions in the community, and then and bearing in mind all the time the context and environment that we want this program to happen in. And this approach recognizes the value of a practice-based evidence pathway when designing and evaluating this population health intervention. So going on now, I wanted to put up this slide just to show these pillars of evidence in a bit more detail, and also it will link back to some of the previous work that was done to show you how the different elements help to inform the program itself. So Move for Life used this evidence-based pragmatic approach that I spoke about in the previous slide, and you can see then in terms of the different pillars. So on the screen here, you'll see that the research component, which is your research evidence base, the top left-hand corner, where we augmented the existing physical activity programs using this research evidence. So we're looking at research studies, theory, evidence-based guidelines for effective community-based physical activity programs, looking at that evidence. And then if you look at the top right, and the pillar below that, so the practice expertise and participants' values and preferences, this actually links back to what Andrew was speaking about and to the paper that he spoke about as well, where when you're trying to get practice expertise, it's about gaining the valuable insights from key stakeholders that are in that particular practice setting. And a big part of that was about how to improve participant recruitment, retention, how suitable the intervention would be, and then the potential role then for the peer mentors as part of that. And then with the participants' values and preferences, we wanted to gain important perspectives from former program participants for exactly what Andrew had just mentioned in terms of the feasibility and acceptability of these programs, which is important for lots of the different stages throughout, both in terms of recruitment onto the program as well as acceptability of the program itself. And then context is really important. So context builds into all of these areas because it needs to consider the resources and where it is that this particular intervention is going to be carried out. So it's about balancing the research evidence together with the real world pragmatism, in terms of how it is that this can be implemented then in practice. So I'm going to pass you over to Enrique now, who's going to talk a bit more about how we operationalize these 4 pillars of evidence into the intervention mapping approach. So over to you, Enrique.
Thank you, Amanda. Apparently my video is not, I think you have to grant access to my video, start my video. Yeah, thank you very much. So can everyone hear me correctly and see me?
Perfect.
Perfect, yeah. So in order to implement the 4 pillars of evidence that Amanda has just told us about, we used an intervention mapping approach to planning health promotion programs, which is a relatively well-known approach to the planning of health promotion programs that include physical activity programs. This approach is grounded in a community-based participatory research approach. And what it does is to provide a systematic process to develop, in this case, physical activity interventions that consider multiple levels of influence on behavior in a manner consistent with what Amanda just has told us. If we can move to the next slide. In its original formulation, the approach represents, as you can see there, some form of relatively straightforward and linear process where completion of one stage or one step is seen as necessary for completing the next step. And what we have here in step 1 is the need for developing a logic model of change. This is the step at which we need to, we endeavor to try to understand context, settings, and participants in depth. Step 2 is about developing a logic model of change. And here what we are trying to do is to make our implicit assumptions explicit by articulating a theory of change that actually articulates or explains how we think that intervention is going to have affect the change or have an impact in the real world. In step 3, we select theory-based intervention methods and translate them into practice. This basically means that we develop our intervention strategies, and we have to do this in a way that actually can be applicable into the actual context in which the intervention is going to be taking place. That leads the way to step 4, in which basically we integrate the intervention strategies into an organized program. So we organize temporally in a coherent temporal sequence the different intervention strategies that we have developed in the previous step. In step 5, we consider adoption, implementation, and sustainability of the program in real life context, and this relates to some extent to what both Andrew and Amanda have referred to before in their presentation. And finally, we give consideration to an evaluation plan, to developing a robust, sound evaluation plan to conduct outcome and process evaluation to measure the impact of the program. If we move on to the next slide, the reality though is that things when using intervention mapping or similar planning and evaluation models that help us to design interventions in a systematic way, the reality is not as simple as the theory would suggest. In reality, it was more of an iterative process in which we went back and forth between the steps as needed, and in which at each stage there was a lot of thinking and reflection involved, even though, as Andrew has mentioned a number of times, we were sort of quite pressured in terms of time to deliver an intervention that was plausible in the real world. One of the things that come to my mind here, I remember clearly that we started developing, working with this intervention mapping approach, assuming that the LSP local sport partnership programs that we augmented, they run for 8 weeks, and once we were into the development of the interventions, we found out that some of the programs actually run during 10 weeks and others during 8 weeks. So we really have to do a bit of engineering here and adapt everything. So the different progression of strategies would make sense for a program that runs for 12 weeks, for 10 weeks, and for 8 weeks. And again, that will imply some going back and forth in terms of the different stages of or steps of the intervention planning. Another thing that I want to just stress here, for example, particularly in step 5, considering adoption, implementation, and sustainability of the program in real life context, as both Andrew and Amanda mentioned, this is not something that we just do towards the end of the intervention design. This is something that was at the forefront of our considerations from the very beginning of the planning process. Next step, Amanda. Amanda, please. I'm not gonna get in detail into this because Andrew has already alluded to it. This is and Amanda as well. This is the stakeholder consultation and the rich themes that emerged from this stakeholder consultation, which were particularly crucial or important for us in terms of developing the step one of the intervention mapping, which is the logic model of the program, and step two, which concerns the logic model of change. So this has been published, and you can have access to that. So I'm just gonna keep moving on to the next step. As Amanda has mentioned, we did not, given the characteristics of this of what we were meant to do. I think also Sarah O'Brien mentioned in the overall introduction to this section, this session, that we were trying to do something that could be integrated within existing practice. So that's what we do, is to augment with some behavioral change, proven strategies, some existing programs within the local sports partnerships. Those were, if I remember correctly, Getting Ireland Walking, Men on the Move, Women on Wheels, and the Go for Life games. And the traditional model that these programs have been working is one in which there is a physical activity, an LSP professional physical activity instructor, either a tutor or a sport development officer, that teaches his or her corresponding program for either 12 weeks, 10 weeks, or 8 weeks. And then at the end of the programs, the participants are sort of left on their own in terms of, using the skills and the attitudes they have developed through the program to try to sustain their physical activity behavior. What we try to do is to move, we can please, Amanda, go to the next slide. We developed a three-phase model to try to go beyond the traditional model, in which the physical activity professionals, LSP physical activity professionals, either the sports development officers or the tutors, receive training, and then they teach their program to the Move for Life participant. And as the physical activity professional goes about teaching her or his program, there is a recruitment and training of peer mentors, which are participants, actual participants in the program, that then actually contributes to the sustainability phase of this model. Next slide, please. Expressed in somewhat different terms, this is what you see here. You see the physical activity, the professional physical activity workshop. I'll tell you a bit more about it. This is combined with the peer mentor workshop, and this results in the participants, the Move for Life participants, being exposed to a number of what is referred to in the literature as behavior change techniques, in an environment that hopefully is conducive to increasing levels of physical activity in a manner that can be sustained over time. Next slide, please. Physical activity professional training. So either the LSPs, sport development officers, or tutors, that took place over 2 days, a total of 6 hours, with some homework in between workshops. Particularly the participants in the workshop went home with a goal setting activity to get them a bit more familiar about some of the actual strategies that they were then asked to use with their own participants. I take the opportunity to acknowledge Nolig O'Sullivan, that you can see in the picture, who worked hand in hand with us in the development and implementation of the intervention. And now, yes, sorry, Amanda, you can just now go to the next slide. So what was this training about? The training for the professional physical activity instructor. We work with them in a number of behavior change strategy that were about to help them to, being able to teach behavioral and cognitive skills, things such as goal setting and self-monitoring. that the literature suggests are important to help participants, so people who want to improve their increase their physical activity, to address common barriers to physical activity participation, such as, for example, lack of time or low perceived physical competence. And these behavioral and cognitive skills were derived from theory. It's one of the pillars that Amanda mentioned before, specifically from social cognitive theory. And then the workshop, the two-day workshop also consisted of some basic principles of, still coming back to behavior change. So we have the behavioral and cognitive skills. Then we have a group of strategies that relate to social support, the extent to which participants give encouragement and feel encouraged by other participants. And these strategies were derived from the self-determination theory of human motivation. And finally, there were a third group of strategies within the broad behavior change theme that were extracted from a group dynamics, group cohesion model of exercise that emphasize both task and social dimensions of group integration in exercise or physical activity settings. So things such as the extent to which participants are able to work together as a group and how much they enjoy working together in the process. So the next block of the training was about some basic pedagogical principles. So namely, just again, some basic concepts on how to present tasks or activities to the participants, and then how to provide a specific feedback and encouragement to the participants, so they know where they are, they know what they need to improve, to get better, and so they feel supported by the professionals through the process. And finally, the workshop consisted on some basic notions of motivation and physical activity context. So we covered basic notions of intrinsic motivation and enjoyment in physical activity settings. Notions on how to communicate in an autonomy, supportive way, and this entails things such as acknowledging the perspective of participants and providing choices which are meaningful to participants. And finally, we just cover some basic notions on how to create a mastery climate, which is about focusing on learning and self-reference standards versus focus on performance and social comparison. Next slide, please. Thank you very much. Here you have an overview of the main intervention strategies. I don't really have much time to cover them. Again, what you have on top of it, the main cognitive and behavioral skill-based strategies. In the middle is the social support strategies. And on the bottom are the main group cohesion or integration strategies. If you're interested, this has been recently published in an article that provides detail on the development of the Move for Life intervention. And I wonder, maybe Catherine, if you could please provide a link in the chat for interested participants. That probably would be helpful. We can move on to the next slide. What you see here is the overall progression in terms of the intervention strategies. For example, assuming a 12-week program, weeks 1 to 4 was about the foundations for behavior change. Weeks 5 to 8 was a bit more of a consolidation of behavior change strategies, and the final weeks were about, sort of preparing for the situation in which the participants are going to leave the program, and they need to have a number of resources and skills to be able to sustain their behavior on their own, such as things with relapse prevention strategies. That would be a clear example of this. Here you can also see an example of a session that the SDOs and tutors would cover with the participants. And let me tell you that basically the behavior change content would take primarily place at the beginning, in the introductory phase of the session, and at the end, in the conclusion phase. The main bulk of the session was where the actual physical activity content of each of the programs took place. And you also see an example of one of the handouts that the tutors and SDOs gave to participants in terms of a bit of a homework for them to work on some of the concepts that were conveyed through the intervention. If we can move on to the next slide, please. Some of you may wonder at this stage how effective was. Do you know if the workshop with the professional physical activity
Enrique,
yes,
can I just say we're just at 1:05 going on to, so we have a couple of more minutes.
Okay.
Thanks.
Yeah. So basically what this is showing is we collected some data in terms of levels of confidence for teaching a number of behavioral and cognitive skills. What you see in blue is their reported confidence to teach the people that attended the professional physical activity instructors workshop. So that's their level of confidence to teach a number of behavioral skills. And in orange, you can see their level of confidence post workshop on a scale from 0 to 10. Clearly, you can see that the workshop seems to have effective, at least in improving confidence to teach this type of strategies. Next slide, please. Amanda, we also provided in terms of improving implementation of strategies, online support for the instructors that required that support, and we also asked them to provide some to complete at the end of each section, session, a fidelity report that told us about the extent to which they were implementing the strategies, the changes they needed to implement in some cases, and that gave us a very good indication in terms of the acceptability and feasibility of intervention strategies. This is the peer mentor component, picture of the peer mentor training in Claire. This is the second main component of Move for Life, the peer mentoring training. And I think Sarah mentioned at the beginning, the idea here was to, you can, Amanda, just please, just continue going on the next slide, please. Yeah, just continue clicking there just to see. So the original idea was to have 2 iterations of peer mentor recruitment and training that we were considering, but the reality is that the only thing that we could do is just one sort of iteration because of the realities on the ground. It was difficult to actually recruit to get people interested. So basically, we only had one iteration or cycle of peer mentoring recruitment and training within a given program. If we move on to the next slide. You may wonder what the peer mentoring was about. You can read it here. What was it about? So we basically try to prepare them to be better communicators, to be able to support the work of the physical activity professional during the duration of the program, and then just to be able to enact, to increase their confidence to be able to enact sort of the sustainability phase of Move for Life. So basically giving them ideas of strategies to keep the group together after the regular program was over. Next slide, please. And this is the assumption that what would happen without peer mentor support at the end of the program. Some participants would not be able to sustain their physical activity behavior. Next slide. This is the assumption that at the end of the program with peer mentor support, participants or many of them would be able to sustain their physical activity behavior with the peer mentor support. In case you're interested to know if that worked or not, suggest that you attend tomorrow's presentation on the actual results of the intervention. Next slide, please. Amanda, some final remarks. I'm going to finish with this. I really want to stress the idea that Move for Life, we did not reinvent the wheel. We really tried to do something that could fit with and complement existing LSP programs, and therefore increasing the likelihood of scalability and adoption. In other words, the Move for Life is a behavioral augmentation of existing programs. And just to come back to the point that Amanda made at the beginning of this presentation in terms of the 4 pillars of evidence-based practice, we really think that this work highlights the value of a practice-based evidence pathway as an essential complement to the more established evidence-based practice pathway when designing and evaluating population health interventions. I just want to, again, in case you're interested in knowing a bit more about what the intervention development entail and what the intervention is about, you can see our open access article. And finally, I just want to thank everyone, and in particular the participants, the peer mentors, the local sports partnerships with their sport development officers, the tutors, the research team, and the funders. And if you have any questions, we will be very happy to address them in the section. Thank you very much.
Thank you to all the speakers, to Amanda, Enrique, and Andrew. Really powerful findings, though, and it gives you kind of a more detail of what actually been done on the day-to-day of the studies. We have about 2 minutes for questions, and there was one question for Andrew. So if Andrew's there, what was the lessons learned from Move for Life around the recruiting of men?
Yeah, I think that was first of all, Stephen, that was one of the big things that came out of it from a recruitment point of view. What I'd say is that the program needs to be tailored to get men in, but not only the program, but information evenings and the testing sessions. We need to get them in at all levels of the process. And second thing I'd say is that rather than just having a structured weekly program for men in particular, we probably need to have a regular assessment built into that. And a regular feedback session. You know, how does this need to change? How is it for you so far? So I guess asking them, asking men, I think that's a second thing. Another thing, my own observation is that I think we need to get out there, and that's where having more time and a bigger lead-in thing, but get out there and meet the men in their groups, and men will probably join in groups. You know, where men sheds being one example. So you meet them at where they're at. And the last thing I'd say is that as excellent as all of this is, it might be that there are some people out there that these sort of programs, it just won't be for them. And we've probably just got it in as researchers and as people who are interested in these people, we've got to think outside the box and say, well, if you're not going to come to a program, what else can we do to get you moving for life?
Okay. Thanks, Andrew. And there's another question then for everybody, I suppose, for Amanda and Enrique, you know, so a lot of this is for research purposes to find out the dynamics of what's actually working. But out in the community, there'll be other stakeholders who might not be the sports partnerships or whatever it is, but there might be other groups. How do we use this information to get people more active out in the community beyond a funded project? Because that's where the issues will lie, in our communities. How can we use this information, or what could be used?
I think, sorry, yeah, I think because of the pragmatic approach that was taken here in augmenting existing programs, I think it's about tapping into those existing programs that happen within the community and looking at programs that can live for longer beyond the research project itself. If I'm understanding your question right, Stephen. Yeah. So it's more about kind of what's existing, how do you augment these, and then how do you get more people to participate in those programs? And I think a lot of the elements that Enrique spoke about in terms of being more socially engaged, and that element of it tends to motivate people to return to the activity. You know, because you've the peer support that's there, there's the fun element, and all of those things I think are extra incentive over and above, you know, the feelings that you have and how good you are. And I think that by having these kind of benefits both to yourself as well as the social aspect of it will, you know, will have people coming back for more. And as Andrew said as well, a big part of it was word of mouth. So by people getting other people engaged within the community and having these champions within the community, I think that was a really important element as well.
Yeah. Fantastic, Amanda. Sorry, Enrique.
No, just to add to Amanda's, Stephen, it's just, I think, to me, what is really important in terms of how to maximize or leverage the, you know, the learnings from of something like we have described is, to me, it's crucial to identify who the key stakeholders or knowledge users are, and get them involved from the very inception of the, in this case, intervention, and you know, ensuring that they have input through all the stages of the development, and then so I really think it's crucial in terms of ensuring that whatever knowledge is generated the chances of that knowledge being then applied into the real life context is maximized.
Yeah. Okay, everyone, we're going to take a break now for a few minutes, and we're going to show you a short video, and we'd like you to move for life. So be active during this 10 minutes, and we'll reconvene in a few minutes' time for the second part of the session.
If someone had told me when I was a medical student that there was a medicine that could reduce your risk of premature heart attack and stroke, could reduce your risk of certain cancers, could reduce your risk of progressing to diabetes and indeed dementia, also was the #1 treatment for fatigue and even reduces anxiety, I don't think I would have believed them. But after many years as a family doctor, I've learned that there is such a medicine, and it's free, and that medicine is exercise.
So keep your 2 hands on the ball and move to the side, and don't let your feet twist to the same side. So get a partner there, you're only using 1 ball between 2.
Here we are today in Carron in County Clare, the birthplace of Michael Cusick, one of the founders of the GAA, and we're at one of our older adults activity classes, which we run here every week, every Tuesday around lunchtime for these great people of this area. This is a very rural community, and we decided to set up this project in 2015 in conjunction or collaboration with the North Clare Primary Healthcare team, Dr. Liam Glynn and his team in Ballyvaughan, and we set up 4 groups in Ballyvaughan, here in Carron, in Crusheen, Corofin, to respond to the need that older adults aren't getting the recommended level of physical activity on a weekly basis. And then people have noticed that older adults, because of the nature they're getting older, less activity, balance becomes a problem, coordination becomes a problem, and even just their social interaction with people becomes a problem. So these projects started then in 2015, and now we have over 22 groups in the county taking part, and nearly 600 people taking part weekly in weekly physical activity classes of this type.
When I started to look at things like, how do we change the health of the individuals I look after as a GP or a family doctor in the west of Ireland, or indeed as a researcher when I ask the same question in terms of populations, that idea of exercise keeps coming up, but also the idea of the challenge of getting people to change their behaviour in terms of exercise.
When I think about my clinical practice, and I'm thinking of one patient in particular here, somebody who has a chronic lung disease, but also has a heart problem, and somebody who is elderly and has developed arthritis as they've got older. I think, well, what can I do for them as their GP? And of course, there is a whole wide range of medications that can be prescribed. But there's one thing that I can give them and one thing that I can point them towards that will help all the problems, and that is physical activity. As our physical health starts to disimprove, and as we get older and maybe we develop chronic illnesses, that has an impact on our mental health as well.
Yeah, I had a problem with my shoulder, and so it's been really good. And a couple of months, maybe a couple of months.
Just doing the exercise.
Yeah. My whole body, everything. Yeah.
Absolutely great. And you come once a week.
Once a week.
Yeah. How about yourself?
There's just so many different strands to it, really, because we come as a community, and we get a bit of exercise, and we have our cup of tea, and we're feeling better.
As a GP, people often ask me, well, what do you actually do in research? And since getting involved in Move for Life, I can give them a really good exemplar of what research is all about. And for me, it's about 2 things. One is testing a theory in a rigorous and scientific way. And secondly, and perhaps just as important, is the impact that piece of research will have on people's lives.
It makes you feel so good, and you're freer and able to move a lot better. You know what I mean? More energy, and it lifts your spirits.
The effect of actually moving, of being physically active, not only will help that patient's lung disease and their heart disease and their arthritis, it will also help the mental health. It will help to lift the mood of that person. So I can't think of any other intervention or any other medication that's been developed that will have such a positive impact in such a wide range of health parameters.
I suppose we're coming to the end of this session, and I'm hoping and hoping for the rest of the boys that it will continue, because it is absolutely first class as far as I'm concerned. It's something to look forward to.
Couldn't let it go now. We have 12 weeks put into it, and it's brilliant, most enjoyable.
I was going through an illness, and I had to come in. I had to get out and about. I had to start walking, do my exercises, because it was part of the program, and going through my illness and the amount of friends that I met through this, and it has given me a new lease to life, and I've really benefit from it, and I've got, I think, much fitter now, and really enjoyed it.
Physical activity is a significant risk factor for health. We know that physical activity, or not doing physical activity, being inactive, carries the same risk as smoking. So if we can make people active, we can give them the same level of benefit that we give them if we make smokers give up entirely.
Okay, so we're going to do a little bit of kettlebells in the water.
In terms of capability, if an individual believes they have the physical and the psychological capability to change their behaviour, this is very important. It drives that aspect of the behaviour. So we work with the individuals to change their physical capability through developing their skills in the practical classes, and the psychological capability through teaching things like knowledge, decisional balance, goal setting, through the sports development officers embedding the behavioural change techniques in their programme.
The benefits that the individuals here at the Move for Life programme have shown, both psychologically and physically and socially. They're not only just enjoying the activity, but they're also getting physically active. They're feeling healthy. They're feeling like they're part of a group and part of a community, and they're really, really enjoying it.
So it's a really exciting endeavour. It all began in a very, very small way in one single rural community. And now we really feel we have the possibility of this becoming, upscale on a national level. And hopefully the evidence that will come from this trial will allow us to design very powerful interventions around group activity, around sustaining groups in terms of exercise, and I guess particularly around recruiting individuals into those groups in the first place.
And the thing about Move for Life is it's not just a snapshot in time, it's a follow-up study where we do our intervention, we leave people, and we come back and we revisit them again to see how things have progressed. And the personal stories and the feedback that we've got from real people with real lives as a result of their involvement in Move for Life has been incredible. And as a clinician, as a GP, as a researcher, it is immensely rewarding to see a real impact and a positive change happening in the lives of real people.
So, Ciara, are we ready to go? Okay, a very striking quote there from that video there. We're talking about real change in the lives of real people. a worthwhile statement, I think. So you're very welcome back to the second session of the day, and indeed the second half of this Move for Life conference. My name is Mo Foley-Walsh. I work with the HSE in the Midwest in Health Promotion and Improvement Service. So an essential aspect of any research is, of course, around what to measure, how and why. So our next speakers are Dr. Grainne Hayes and Caera Grady, and they're going to talk to us about measurement of physical behaviours and physical health measures used in the Move for Life study. Dr. Grainne Hayes is Interim Programme Manager for the Physical Activity for Health Research Cluster in the Health Research Institute at the University of Limerick. She has much expertise on the validation and application of accelerometer devices that measure physical behaviours across the lifespan. She's particularly interested in accurate measurement of all physical behaviours across the 24-hour cycle and how these behaviours influence health. She has designed and implemented successful cross-sectional and intervention studies using device-based measurement in both adolescent and older adult populations. Prior to this role, Grainne worked as a research assistant on the Move for Life project, and indeed I had the pleasure of working with her in those early days doing the baseline measures in the community. Caera Grady then is a PhD student in physical activity for health in the Department of Physical Education and Sports Science at the University of Limerick. Previously, she worked as a research assistant and interim project manager on the Irish Physical Activity Research Collaboration, or IPARC, and on post-primary active school flag projects. Caera has experience of working with older adults on the MEDEX program at the Sligo Institute of Technology, and for her master's degree, she studied sedentary behaviour in older adults with osteoporosis. So I'm going to hand over now to Caera and Grainne. Do remember to add your comments or questions in the chat box for discussion after the presentation.
Thanks, Mo. Just see, is my screen sharing there? Okay, and it's in presentation mode.
Yeah, perfect.
Perfect, great, thanks. Thank you, everybody. So today I will be presenting, myself and Caera will be presenting on, as Mo said, the measurement of physical activity and the physical health measures that were obtained within the Move for Life study. So to give you a brief overview, over the next 30 or so minutes, we will take you through the measurement of physical behaviours and physical health measures that we used in the Move for Life study. So we aim to cover each test in a certain format. So what the test measures, how it was set up, how to assess it, and we'll present some normative values. And we also have some activities for the audience. So if you want to keep an eye for this try it now sign or marker, we're going to get you to try a few of these tests at home. So just to start off, in terms of physical activity, well, physical activity is defined by its intensity. For example, we artificially divide physical activity continuum into 3 intensity bands, which are all defined by multiples of resting metabolic rate. So light intensity physical activity includes activities that are lower than 3 METs, and examples of this would include sweeping or cleaning a bedroom and strolling around. Moderate intensity physical activity then would include activities that are between 3 and 6 METs. And there is basically a noticeable increase in your heart rate and your breathing. So when prescribing moderate intensity physical activity, we would suggest to use the talk test method. So if you're walking with a buddy, for example, you may sweat, but you should be able to carry a conversation, but you shouldn't be able to sing. So examples of moderate physical activity could include brisk walking and heavy gardening, for example. And finally, vigorous activity is high intensity exercise, where you would be breathing much harder and sweating. And an example here would be running and cycling fast, basically. So generally what we can take from this is that metabolism is good for you. So vigorous physical activity is possibly best. However, since vigorous physical activity is a tough ask for non-exercisers, we generally monitor moderate to vigorous intensity physical activity, which is most often mainly moderate and not much vigorous. So before we can accurately describe the interactions between physical behaviours and health, first we need to accurately measure and quantify physical behaviours. And of course, there are many ways of measuring physical behaviour that can be achieved within a lab or within the free living environment. For example, self-report measures. Participants can report their activity via 7-day physical activity recall or activity diaries or questionnaires. Now, the most effective and simultaneous, the most invasive measurement of physical behaviour is behavioural observation. So this is where a researcher would document detailed information about the frequency, duration, and intensity of activity during a period of observation. It exceeds most methods in its capacity to capture both the type and the context of physical activity, but it's very time invasive, and hence we don't really use it that much. Moving more to lab-based methods, now through the use of calorimetry, participants' energy expenditure can be measured and quantified using, for example, doubly labelled water and indirect or direct calorimetry. One of the major issues with direct calorimetry and doubly labelled water is that they are very costly, and they really require expert personnel to carry out the measurements. So within field-based testing, motion sensors, things like pedometers and accelerometers have become the preferred method of choice, and for many reasons really, but they are cost-effective, they're easy to use, they're comfortable for the participants, and a large sample of people can be tested using them. So for the Move for Life study, as we mentioned yesterday, we use the active PAL accelerometer to measure physical activity and sedentary behaviour. So from using this device, we were able to assess the amount of time the participants spend sitting, standing, lying, and stepping. Participants that were deemed to be inactive and over the age of 50 were fitted with the active PAL. It was worn on the anterior aspect of the right mid-thigh and waterproofed using a nitrile sleeve and a tegaderm dressing. Now, a tegaderm dressing is just, if you've ever been into a hospital and you've gotten a drip and what secures the needle into your hand. So that's basically what it covered. It's waterproof. The participants wore the active PAL for a period of 6 days, and they were only instructed to remove the device if they were submerging themselves in water. So they were actually able to wear it for showering. And usually if we were using this in younger populations, we would say, remove it for contact sports, but that obviously for this age cohort wasn't applicable. So once the participants returned the active PAL 1 week later, the amount of time spent sitting, standing, lying, and being physically active was quantified for each participant. So what we did then was we provided some feedback to the participants at the end of the Move for Life study. So after they had done the follow-up, the 3 testing periods and the follow-up. So each participant would have received an output that you can see here. And it basically provided a graph of their activity profile. And it gave a breakdown of the amount of time that they sat or that they were reclined, which can be observed here in the yellow. The amount of time that they stood, which can be seen here in the green. And it also showed the number of steps that were taken for each day. So they could observe that for each day and see how they progressed over the 3 time periods. But it's important to note that we only did this at the very end of the intervention. Now, some people might say active PAL might be a little bit expensive, but you can, if you're running your own interventions, you can do something like this using a Fitbit device or some of these smartphone applications as well. So it's important to bear that in mind. So just moving on to the first of the physical health measures that we did was the body mass index. And I'm sure many of you here are very familiar with this, and it's a measure of a person's weight in relation to their height, and it's probably one of the most popular field-based tests used to give an indication of obesity. So the protocol we did was we just took the height and the weight measurements and we recorded them to nearest 1 centimeter and 0.1 centimeter, and weight was recorded to the nearest 0.5 of a kg. We recorded the measures twice, and if there was more than 5% between the two, difference between the two measures, we recorded it a third time. And then BMI was calculated as weight divided by the height in meters squared. So just to present you with some normative values. So as you can see here in the blue box, as the BMI increases, so too does the risk of obesity-related illnesses. So those underweight up to obese, they have a higher as you move into the obese category, over 30 kg per meter squared, you have a higher risk of obesity-related illnesses. Now, the second test that we did was with body composition, so it was waist circumference. And I'm going to show you a video here. Now, just to make you aware that the video is actually taken on adolescent participants, but I think it's a really good video because it highlights how sensitive this measure is, because it can be a very sensitive measure for most participants. So it's imperative that we explain the procedure in step-by-step format to each participant. So I'll play the video here to show you how to take this measure, but generally you face the participant straight on, you look and find—
the measurement is taken in private.
Sorry, Ciara. So you look to find the narrowest point of the abdomen as the participants inhale. And then once the participant has fully exhaled, you then take the measure. It's important to note here that if no one point is evident, so if you can't see a narrowing of the abdomen, then you should measure halfway between the lowest rib and the iliac crest and take the measure there. So, with further ado, I'll pass you on to Ciara to play this video, and just to be aware that we'll put up a table there and you'll see that the higher the waist circumference, again, it's like BMI, the higher the waist circumference, the higher the health risk. A healthy waist circumference for men is generally around less than 94 centimeters, and for females, it's less than 80. So if you just want to sit back and just watch, it's a 2-minute video, and I think it really demonstrates and describes the test quite well.
Make sure there is another person there to witness the assessment. Ensure participants are dressed in light clothing with a separate top and shorts or pants. Example, not a one-piece leotard or dress. Have children roll up their own shirt and secure the rolled up shirt with clothespins. Have the child show you where they think their hip bone is and confirm it by palpating the upper right hip bone until the uppermost lateral border of the iliac crest is found. Make sure you ask the child if it's appropriate for you to confirm the location of the hip bone. Mark the top of the iliac crest. Repeat the landmark so that both the left and right sides are marked. Standing on the participant's right side, position the measuring tape around the abdomen so that the bottom edge of the measuring tape is at the level of the landmark. Ensure measuring tape is in a horizontal plane between the two marks. If there is a visible difference between the marks, use the mark on the right side as the guide to ensure that the measuring tape is parallel to the floor. These are common mistakes made during the test. Tape not on mark. Tape too tight. Tape too loose. Hands on hips. Arms crossed. Shirt down.
Perfect. So I'll pass you on to Ciara now, and thank you very much for your time.
So I'm just going to take you through the rest of the test. We have about 5 more tests that were used throughout the Move for Life study. But first of all, as we told you at the start, and keep an eye out for this measure. So I'm going to be a pain and get everyone to stand up now and move their chairs and try and give this one a go. But before we do that, just to let you know, this sit to stand test can be performed in single or in multiple reps. So what it measures is the ability of the person to rise from the chair It's a complex test that requires lower limb strength, range of movement, balance, and it's included in several risk assessments. So what you're going to need is a chair and a stopwatch. Sorry, my screen's not moving on there. But your participant is asked to rise from the standard height chair about 40 centimeters, and this can be with or without an armrest. But the important thing is for the participant to actually not use their arms physically to help them up off the chair. And before they start, you can test with a single rep of sit to stand to make sure that they are able to do it, and then you can get them to start by doing the 5 reps and timing it to go. So I'm going to just actually stand up now myself and measure it, and if everyone else wants to join, you can, if you have your stopwatches handy, you're going to just get them set up. And then you're going to say go. You want to make sure, if you can, have a chair up against a wall, and the person has to sit erect in the chair, so your back should not be pressed against the back of it. So I'm going to start in the seated position, and I'm going to press my timer, and I'm going to perform 5 reps. Okay, sorry, stop it then when you get back down into the chair. So just to say then, so an inability to rise from the chair 5 times in less than 13.6 seconds is associated with an increased disability and morbidity. So just to say there, I can show you on my watch, it was 9 seconds or thereabouts. So I don't think I'm at risk of having any morbidities or disabilities. Meta-analysis results demonstrate that individuals at times for 5 repetitions of this test exceeding the following can be considered to have a worse than average performance. So you can just see in a little blue box here that sorry, now 60 to 69 age bracket would be about 11.4 seconds, and 70 to 79 12.6, 80 to 89 14.8 seconds. I know a lot of you here may not fit into these age brackets, but you can easily look up what is recommended for your age category. But generally, as I said, unless you're exceeding the time stated above, then I think you're okay. So the next test then was the grip strength. Yes, so this is a measure of upper limb strength. It's an indicator of sarcopenia and mobility limitations. So what you're going to need is a grip strength dynamometer and a stopwatch. You're going to need to make sure that the dynamometer is zeroed prior to each trial, and the handle is adjusted as required. Adjusting the handle should sit on the first metatarsal, and the hand should rest on the 4 middle fingers. So your first metatarsal being the space between your palm and the start of your fingers, and then you're sitting on your 4 fingers, which should sit perfectly like that. So we're going to watch this video, and they explain quite well and show how it is done. Please note that there is different protocols followed, but for the Move for Life study, the one that we followed is that there was 2 measurements taken on both the right and left hands, and then an average was taken for each hand. I think in this video they take 3 attempts and take the best score, but again, it is a good demonstration. So you're supposed to keep your hand down by your side and squeeze in a static isometric position. So I'm just going to play this one now.
In order to perform this test, first of all, we need to make sure that the tips turned up and set to 0. Once you've done that, you need to adjust the grip diameter so that it fits perfectly into your participant's hand. This means that their fingertips and their palm are held correctly in
in right positions. The participant then places the grip diameter down by his side, and he will grip the diameter the second for 5 seconds. At the end of those 5 seconds, Mr. Hughes will then get 1 minute rest. After that 1 minute, he will test it then. He will perform the test 3 times, and it's the best score taken. Are you ready?
Sorry about that, guys. I think there might be a problem with the sound. Grainne, could I get you to unmute yourself there, because I think the sound is coming through your computer instead of the actual share. So as you can see there, they got the participant to squeeze the dynamometer for 5 seconds at a time. And the tutor just recorded that time and told the participant when to start and stop. You may wish to do a practice run for the participant and just to demonstrate how that is. So they showed a 1 minute rest in between each attempt, but what you can do is to switch hands. So start with the right hand, then alternate to the left, to give the participant a bit of a break. So some of the normative values to watch out for is for men's on the right hand. You can see here that 49 kilograms for the right hand and 47 kg for the left, and for women 29 kg on the right and 27 on the left is what you would be looking out for on for the hand grip strength test. So the 6 minute walk test is next. So this tested walking endurance. So it's the distance that a person can comfortably walk in 6 minutes at their usual speed. Just to note that you will need a stopwatch, a tape measure, a bean bag, 2 cones 30 meters apart, and a chair or a wall or something for the participant to be able to take a rest. So the participant can slow down and stop if necessary, and they can choose to drop out at any stage. But just to be sure to record that the stopping time of which they stop, and then the duration of the stop as well. So you can demonstrate yourself by walking 1 lap and just briskly turning around the cones. And the stopwatch will start as soon as a participant moves their foot to take a step. So we'll watch this video now in a second, but also just to say that you're going to give a series of instructions to your participants. You're going to tell them to start now, and then after 1 minute, you're going to say you're doing well, 5 minutes to go. With 4 minutes remaining, you're going to say, keep up the good work. You have 4 minutes remaining. 3 minutes to go, you're going to say, you're doing well, you are halfway done. 2 minutes to go, keep up the good work, you have 2 minutes remaining. And with 1 minute to go, you are doing well, you only have 1 minute to go. So again, I'm just going to show you this video, which they kind of give some pretty good, oh sorry, the last one was with 15 seconds to go. Then you're going to tell them, you're doing well, I'm going to tell you to stop, and when I do, you're going to stop right on the spot. You're going to bring your beanbag with you and put it there, and this just gives the participant the opportunity to go take a seat and rest if they need to at that point. Then you're going to measure the distance between the beanbag and the last cone, and then tally the distance according to the number of laps that they did. 1 lap, 1 down being 30 and back 30, so a total of 60. And you're going to record that, and that is the distance that they will have covered. In this video, they tell you some contraindications for the test, so reasons to stop, which is quite important as well, especially if you're dealing with people with comorbidities. Grainne, I think I'm going to need to get you to unmute because I can't.
Over 100
or above, right, you're not going to want to do it. If their resting heart rate is over 120, okay, you're not going to want to do it. Yeah. So, if there's any unusual concerns health-wise, maybe you should see a doctor or, don't do this if there's concerns. Yeah, and the test is going to be stopped if the person starts to have chest pain or if they really become short of breath and it's just intolerable. Leg cramps, if they're staggering, they become sweaty, sure, or ashen, pale looking. They should feel just normal, maybe a little fatigued. The problem is that some of the standards here are a little bit off on the way that people do this. But you always want to have them walk, usually at a comfortable pace, not as fast. Don't say walk as fast as you can. Just say walk at a usual pace or a comfortable pace. Sure. They should wear comfortable shoes. As far as encouragement, if you're doing the test, you want to make sure you give the same amount of encouragement each time you test, because encouragement does help people go further. The motivation, yeah. You might want to say nothing at all. Right. I mean, that might be the best of all. Sometimes people even do a practice trial. Sure. This. So if you're going to do it from one time to another, doing it in the same location, same atmosphere, right, same shoes. So Brad, as you start doing it, okay, you're going to go ahead and start. And you're walking down. If he should get tired, he can do one of two things. He can either lean against the wall, which we don't have any wall here, or he can actually sit down if he gets tired. So I could lean against something of this. So this is, then the clock keeps going? Yep, the clock keeps going. So this is working against you, as you're obviously not going to get as much time down. If you get rested up and you get up and go again? When you're ready to go again. Okay. So it's a very simple test to apply. It's very helpful. There are some standards, there are some results, but they all kind of vary a little bit, and they have them for like. So, one thing that they said there during that was the notice of when you're testing over 2 different time points, which was very relevant to the Move for Life study. You want to make sure it's the same conditions, and that is the importance of repeating the same cues. So the ones that I called out just before we started the video there, so it had to be the same for each participant and the same at each time point. So they're just some important things to note. And as you can see here, the normative values shows that if you can cover more distance, you're kind of categorized into the healthy category. Anything more than 350 meters is deemed in the healthy category, and anything under 315 meters we're at an increased risk. So the next test then is the timed up and go. So this tests functional mobility required for activities of daily living, and it's an indicator for those who are at risk of falling. So again, what you're going to need is a chair, some measuring tape, and some actual tape for the floor. So there is no time limit, and the participant may stop and rest, but they're not allowed to sit down once they have gotten up and they're starting to walk. If the test is not conducted correctly, they can repeat it again. For example, if the participant stops at the line and doesn't come back, if they don't sit down, or if they don't walk all the way to the line. You can also make this test a cognitive test by counting backwards from 30 in multiples of 3, or by naming animals. So the instruction that you're going to give your participant is to stand up and walk as fast as possible, yet safe, to the line on the floor, and turn around and walk back to the chair and sit down again. So very quickly, I'm just going to skip forward in this video to the instructions.
To conduct the test, have your patient sit on a chair with possible walking aids at hand. Then explain the procedure to your patient as follows. When I ask you to start, please get up from your chair and walk at a comfortable and safe pace to the mark 3 meters away from you. Cross the line, turn around, and return to your chair and sit back down again. Could you repeat that to me? If your patient has understood the process, ask the patient to start the test. Once you ask the patient to start the test, you will start the stopwatch and only stop it until the patient is seated again. Okay, Kai, you may start. The patient is allowed 1 practice round, and 1 round is timed.
So you can see there that the normative is for anyone who can, if you're over 14 seconds, and this is an increased risk of falls, especially in community dwelling older people. So finally, just moving on to the last test. I know we're tight on time now, but this is the single leg stance test, and this tests balance. So what you're going to need is a timer and a chair for something, or close to a table or something to hold on to if they lose balance during the test. So I was hoping that we could be able to try this now. So very quickly, I'm going to stand up from my chair if anyone else would like to join me. I'm going to set a timer. I mightn't exactly do 30 seconds, but we'll give it a go anyways. So what I'm going to do is lift my foot up from the floor. So your foot can be placed anywhere as long as it's not being held on the leg that's placed on the ground. So it can be free above the ground, whether it's in front of your body or behind your body. You want to place your arms down by your side and lift your foot off the ground, and hold for as long as possible, or until I say stop. So if the foot moves, touches the ground, or your hand makes contact with the surface, then you're going to stop the test. So very quickly now, I'm going to press the timer and time myself. So research. Okay, so go. You can keep going for as long as you can. At the moment, I'm at about 15 seconds, and I'm going to stop now with the essence of time, but I do feel like I could have went on for longer. So it just shows here that less than 10 seconds indicates balance impairment, and less than 5 seconds may indicate a fall risk for older adults. And finally, just to show you the participant report cards. So at the end of the Move for Life study, participants received their report card, which gave the results from each of the 3 time points and which measures were taken throughout the study. And they were able to see if they improved on any areas, or if there's any areas where they might need to further improve. And you can see there we gave some tips to improve physical activity in their daily life. And also we gave them a scorecard which explained the test and provided the normative values so they could see themselves where they fit into this bracket. These are also available on the Move for Life website. And finally, just to say thank you, like everyone else has already, just to thank the participants, because really there would have been no study without the participants, but also the funders, the research team, and everyone else involved in Move for Life, and also to Grainne, who is presenting with me here today. I'm going to pass over to Mo now, who might direct us with any questions.
Okay, thanks a million, Ciara and Grainne. It's the first time I've chaired a session where I've been standing on one foot for a time, or getting up and down off my chair timed. So very practical session there. We have a question for you there. Grainne, you might like to respond to this. Can you provide advice on how to organise a range of measures, such as you presented to us there, for a group of people, and tips for making this enjoyable for participants? Because in fairness, I'd like to add a little to that. Those videos are very clinical. They presented what to do, exactly, very measured, very scientific. But the real experience was in a group context, in a community centre. It was social, there was banter, there were refreshments, there was the encouragement that was spoken about there earlier. So would you talk to us about that?
Yeah, absolutely. Thanks, Mo. So the first part is the question, I think, was just in terms of organisation. So obviously when you get a group of academics and stakeholders together, we go to the research and we discuss what the best measures will be. So that's what we did, and it was very informed by evidence-based practice. But I think the key word in the question was organisation, and organisation is key when you are working with a project or an intervention that is of this scale. That organisation in terms of equipment, in terms of personnel, like we could have up to between 15 and 20 testers on a night. And that would have been a mix of PhD students, research assistants, and people from Healthy Ireland, from the HSE, that were all trained in the protocols, so that we had standardization across the board. And timetabling is imperative as well. So it's basically organizing and coming up with what if scenarios. So you have to kind of think 3 steps ahead all the time when you're testing. So and one thing that's very important is timekeeping and being punctual, because especially when you're working with this demographic, they do turn up early, so you have to be there, and they want to get in and out. No one wants their time wasted. So those are just some of the things that I would recommend. In terms of making it enjoyable then for the participants, I think you touched on it there. It's the social element. Like, some of these people mightn't have seen somebody for, a week or a day or whatever it is. So it's for us as researchers, to make it enjoyable, we need to treat them as humans and not as participants of a study. So again, they're normal people coming into, and you have the crack, you have the banter, you ask them how their day is going, you explain to them what they're doing and why they're doing it. And I think that's what makes it enjoyable, is just to keep it personable as personable as you can, really. So those are some of the things. I hope I've touched on I've answered the question there.
And in fairness to you, there were 2 questions in one. So absolutely. So you've spoken about the organisation, the timetabling, the what-if scenarios, timekeeping, and really importantly, and it's come up in the earlier session, you were talking about people with real lives, not subjects of a study.
Yeah.
Very important. And maybe can I ask you then about that other piece? Like we saw there in the videos, there's a very clear protocol to follow.
Yeah.
And then we saw the real world, what happened. Yeah. And it was really exciting. It was very sociable, and the teas, coffees were a very important element of it. The conversations that people had when they were being measured. What difference do you think that made, doing it in the community centre rather than in a clinical setting, one by one?
I think it adds to it also for participation. I think it would have for compliance, because there was a great atmosphere there. If you'll remember when we were there, people. We always tried to get people's names, to remember their names, or you could have 700 participants, but everybody had a name badge, but you still tried to remember them and tried to engage with them and see how they were going. So just making it, again, going back to that point of making it as personable as possible. It was very important, I think, to do the scale of the study that we were doing. We had a very limited amount of time, so we had to use the community centres, and we had sectioned them off, sectioned the different tests, and we worked at it like a conveyor belt, if you want, or a circuit. And when the participants came in, we explained to them what they'd be doing. So the first part was the questionnaires, and then they'd go and get their height and weight and the physical measures, and the last test they'd do would be the 6-minute walk test. So we familiarized them with that protocol on the first day, and then they just seamlessly fell into it on the second and the third day. So that's how we did it. And then they'd come, when we're booking them in, they might come with their buddy, or with a crew might carpool together. So allowing that to happen, I suppose, as well, making enough spaces during the time slots that were available for a few people to come, that were coming from the same area or whatever.
Absolutely. Thanks, because that's very true. I'd forgotten that. The name badges.
Yeah.
It's back to that organisation. It's back to the timetabling, the what-if scenarios you spoke about there. And I know this is touching back to the earlier presentation that Enrique and Amanda spoke about it. I'm going to put you a bit in the spot there, yourself and Ciara. I think it was so exciting the way you took measures that are grounded in very robust evidence that apply to the real world. They measure real life functions in day-to-day life, but it was extremely practical, and it worked in the real world rather than. Would either of you like to comment a bit more about this evidence-informed approach, this practice-based evidence rather than simply the evidence-based practice?
Or Ciara, do you want to take that, or do you want me to take it?
Go ahead, I'll just to you.
Yeah, so I think it's very important. Again, it goes to the scalability of the project, and also these are measures that would give us an indication of the health in terms of what we had in terms of funding and what we had in terms of facilities and resources and what we could do in a limited time frame. So that's where the practicality came into it, and what would tell us about this demographic. What would a sit to stand tell us? What would a 6-minute walk test? What would that? So all these tests were carefully picked. But there was a number of factors that were involved that maybe constrained it a little bit. In an ideal situation, you would love to get some bloods taken, but we just didn't have the time, and I think of the measures that we did pick, we can see some pretty good evidence there that we should probably scale up this and expand it, and I'd be hopeful that in time that maybe we could receive some funding to actually roll this out, because you can see it's some valuable information that's been disseminated from it.
Thank you, Grainne. And it's really important as we come to the end here, there's that whole piece about scalability and rolling this out. That's the key piece. And I think it's a good way to come to the end of this session. So as we come to the end of day 2 of this conference, I'm just going to recap on what we've seen and heard with Sarah O'Brien, their National HSE Lead for Healthy Eating and Active Living, the programme. And she opened today's events and really it was a good opening there. I thought we got the policy context for Move for Life, and we got a really, really good overview of the Move for Life study. We then had that really lovely video. Again, that phrase of real change in the lives of real people resonated with me. Then we moved on and we learned about getting the message and the strategy right when it comes to recruiting participants for a study of this nature from Dr. Andrew O'Regan. Dr. Enrique Garcia and Dr. Amanda Clifford then described the Move for Life intervention development. And I was very struck there by the 4 pillars of evidence-based practice, really practical and very effective. We then had another excellent video, and the key take-home message: physical activity is the best medicine. And then we had Ciara and Grainne, who took us into the second half of the session. And they spoke to us about the measurement of physical activity and the measures used in the Move for Life study. So I want to just thank you all, and thank all of you who joined us today, to our presenters, to our contributors. We'll be back here again tomorrow at the same time in the same place to share more very valuable learning from the Move for Life study. And don't forget, there's still time to register for the last day. Just go to moveforlife.ie. Thank you.
Thank you, Mo.
Thank you.